Thank you. We all know that now we have moved to the era of precision medicine in lung cancer, and last two talks addressed about how things have changed in all positive and non-small cell lung cancer. With availability of more and more drugs, the responsibility lies on the medical oncologist to choose a optimal first-line treatment and how to sequence them. Though data is not very well clear on how to sequence, but there are a certain pointers like cost, whether patient, what is the tolerability of patient, efficacy, be it a CNS efficacy or the response rates, PFS, OS. With all this data, we can make certain suggestion to the patient. Ultimately, it is patient who decides that whether he can afford one or over the other. But keeping in all mind, how do we choose or how do we sequence? We saw that there is a lot of things while choosing in all positive. Similarly, we have options in EGFR mutant non-small cell lung cancers also. Let's look at what does evidence suggest. So briefly, I'll be looking upon EGFR mutant non-small cell lung cancer. What is the PFS and OS data for various EGFR TKIs in the first line treatment? And also, is all EGFR mutated lung cancer, are they same or are they different? And how do we manage brain metastasis? Because we know that these onco-addicted tumors, they have a high propensity to have a brain metastasis. So even while on therapy or upfront, there is a higher incidence of brain metastasis, be it a ALK positive or a EGFR mutated non-small cell lung cancers. And ultimately, it boils down to safety data. So these are the salient points which we'll be looking at in today's talk. So looking at the prevalence of EGFR mutations, we all know that the EGFR mutations prevalence varies by geography. It roughly varies between 10 to 30% in the Western data to Eastern Asia countries are somewhere around 40 to 50%. If we look at the Indian data, the largest data for India comes from the Tata Memorial Hospital. The Kumar Prabhasar trial looked at 907 patients. Among them, they suggested that 23% patients had EGFR mutations. However, if you look at the other data from India, they vary from 20 to 50%. So I believe that somewhere around 30 to 30% of our patients have EGFR mutations in our country. So how did we evolve over the management of EGFR mutated non-small cell lung cancers? Way back in 2003, before we knew that there is a EGFR mutations, Geftinib got approved for use in non-small cell lung cancer. Later, when they serendipitously, when they found out that some of these non-small lung cancer are doing extremely well on Geftinib, but not all the patients are doing extremely well on Geftinib. When they looked at these particular set of patients, then they discovered that those who are having EGFR mutations, they tend to do well. Later on, it was fine-tuned to use these kind of targeted TKIs for only those who harbor EGFR mutations. From the story of Geftinib, it evolved to a second generation like Afatinib, Decometinib, to third generation TKI like Osimertinib. Nowadays, even we are seeing more and more combination therapies in management of EGFR mutated non-small cell lung cancer. So what are the approved EGFR TKIs so far we have in for management of metastatic non-small cell lung cancer? That is first generation TKI, either Erlotinib or Geftinib, or second generation TKI, Afatinib, Decometinib, or third generation TKI, Osimertinib. Are all these same, or how do they differ? So these are certain silent points like what is the activity range, whether they cover only mutated EGFR, or they affect all EGFR receptors, like EGFR receptors may be present in the skin or GA system. So they are, do they affect even those normally occurring EGFR receptors, or do they cover other EGFR family of receptors like R2, R3, or if they have any specific resistant mutation, do they cover that? So in that, they have a varied differences. So like first generation, they act upon both wild type EGFR and intrinsic EGFR, but they do not cover pan-HER mutations like R2 or R3 are not covered by first generation TKI. Similarly, they have a minimal activity against T790 mutations. So that's what we see. If you put a patient on first generation TKI, majority of patients will develop T790 mutations when they progress. What about second generation TKI? Second generation TKI, they are irreversible. Unlike first generation, they are reversible. Second generation are irreversible, and they also have a broader activity. They act on wild type, they act on HER, and some minimal activity on even T790 mutations. However, osimertinib, some of the silent points of osimertinib, it is very specific. It acts only on intrinsic mutant EGFR, very less activity on wild type EGFR. So, I mean, toxicity wise, it is preferable, and also it has a very good activity against T790 mutations, which is a commonly seen resistant mechanism on patients who are treated on a first generation TKI. So, what is the available survival outcome data for these EGFR TKIs? We all know that, I mean, initially when geftinib and erlotinib were compared against chemotherapy, it has shown a PFS benefit without any OS benefit. However, this afatinib, it was compared against standard of care, that is geftinib instead of chemotherapy. In this trial, if you look at this Slection 7 trial, the PFS, so curves are almost till the 50th percentage, the curves are almost, they are overlapping each other. Even if you see median PFS, it is 11 versus 10.9 months. Though they could show that it was statistically significant, I do not see any clinically meaningful improvement in the median PFS if you go upfront with a afatinib compared to geftinib. But towards the tail end, you will see that certain population do get a benefit, that probably after 40% of the patient, in them there is a suppression of curve. If you look at the 18 months, it is the PFS is 27 versus 15%. If you look at 2 years, there is a 10% gap, that is 18% versus 8%. So overall survival, again, there was no OS benefit if you compare afatinib versus geftinib. So either you can go for upfront geftinib or afatinib. So another trial that is looked at as similarly the second generation TKI decomitinib versus geftinib, that is Archer 1050 trial. So in this trial, we can see that there is a clear separation of curves, and the curves kept on separating with the time. It is not that at certain point they separated and again they are merging. So it is a very good separation. So, and also the clinically there is a meaningful improvement in the PFS. So it has improved from 9.2 months with a standard first generation TKI geftinib, with the intervention arm, that is decomitinib, having a median PFS of 14.7 months. And if you look at the overall survival, initially when my first data was published way back in 2017, there was, I mean, like initially there was a no benefit, later on there was a benefit, and again the curves were merging each other. However, the final data when it was published in 2019, the separation of curves, even with the time, even at 4 years or 5 years, the curves are well separated, with a median OS improvement from 27 months to 34 months, which was not seen in the another second generation TKI trial, that is Slection 7. This is the first second generation TKI which has demonstrated a survival benefit compared to first generation TKI. So apart from that, we also have a third generation TKI, osimertinib. We all know that osimertinib is a standard of care in the management of non-small cell lung cancer. The trial which has shown a efficacy of usage of osimertinib in first line is a FLORA trial. If you look at the PFS benefit, there is a wonderful separation of curves, and it is almost doubling of PFS from 10 months to 18.2 months with a hazard ratio of 0.46, means there is a 54% reduction in having an event at any given point of time if you go for a first osimertinib compared to first generation TKI. So if you look at the final OS, again osimertinib has shown a significant improvement in OS from 31.8 to 38.6 months, with hazard ratio, with clinically magnitude of benefit is roughly around 6.8 months, with hazard ratio of 0.79. So mortality reduction was roughly around 20% if you go with osimertinib compared to first generation TKI. So another important question, with more and more availability of TKI and with more and more data evolving, so similar to what we had seen in CRC right and left, so is all EGFR mutated non-small cell lung cancer are same or different? Earlier we added data that if you look at if you look at the various EGFR mutation, particularly those who have mutation in DEL19 or exon 21 L858 or they have a good prognosis compared to other EGFR 20 insertion mutation or T790 mutations. Compared to these two group of patients had a very good prognosis with the EGFR TKI. But these two, again, they are same or they are different. So there is a certain data that how do these behave. So when compared with the chemotherapy, EGFR TKI, that is first generation TKI, had a better outcome in EGFR 19 deletion and exon 21 L858R mutations. And also they noticed that in EGFR these mutations, if you compare Del19 mutation versus L858R mutations, there is a higher propensity to have a co-mutation in those who harbor a L858R mutation compared to Del19 mutation. In this data, they have shown that only 4% of the Del19 mutation patients had a other co-mutations like either compound mutations or other mutations were seen only in 4.7% mutations, whereas in L858R mutations, they had a 20%, means 1 in 5 patients harbored other mutations like T790, S768I, 833V. All these mutations or other multiple mutations were seen roughly in 20%. We know that if there is a other co-mutation, chances of that playing some other role will be high. So it may act as a resistance mutations or it may decrease the efficacy. So similar data, when they looked at whether patients had a co-mutation or not, we can see that those who had this orange line represents those who had a concomitant co-mutations. Those patients had a poor survival outcomes. If you look at the PFS among those who had a co-mutations, it was 6.2 months when treated with a EGFR TKI compared to 18 months when treated with in the population who did not have any concomitant mutations. So similarly, there was also significant OS benefit. Overall survival was much more longer in the patients who did not harbor concomitant mutations compared to those who harbor a concomitant mutation. So definitely occurring of concomitant mutations is a poor prognostic marker, and also the L858R population, they harbor a higher number of concomitant mutations. So compared to Del19 mutations, though these populations tend to behave badly. So what do we have a data about this L858R population? Do we have any data that how do these second generation TKI do? So in this Archer 1050, roughly around 200 patients were having L858R mutations. If you look at the PFS benefit, it impacted not only in the overall population, even in the L858R population, there was a OS benefit from 27 months to 34 months to the tune of 7.1 months difference was there. So, however, if you look at the osimertinib data, how does this L858R population do on osimertinib compared to geftinib? We can see that curves are hardly separating. So there is a hazard ratio is well crossing from 0.7 to 1.40. If you look at the Del19 population, osimertinib is a clear winner. It has shown a clear efficacy in EGFR 19 Del19 population. L858R population, though the population was, quite sizable, that is roughly around 35%, that is 207 patients had a L858R population. Still, we do not see that it is showing a clear efficacy when compared to first generation TKI. It is crossing the line of unity. So the data for osimertinib in FLORA trial, though that is a subset analysis and exploratory analysis in nature, but with the whatever data available, we can say that the data is not very convincing for L858R with osimertinib. So another second point while choosing one is whether all mutations are same or it is a heterogeneous disease. We address that question. The second question is, depending upon the site of metastasis, do they behave bad? We all know that these onco-addicted mutated patients, they have a higher propensity for brain mutations. And those who have a brain mutations, they behave badly. First, because the brain penetration is low with the drugs. And second, they have a poor prognosis. So first, LUX-Lung trial looked at a CNS activity of afatinib. In this trial, in the LUX-Lung 3 trial, there was a trend towards improved PFS for patients with brain metastasis who received a second generation TKI compared to chemotherapy. In the LUX-Lung 6 trial, there was also trend toward improved PFS for patients with a brain metastasis who received afatinib compared to chemotherapy. That was 4.7 to 8.2 months. PFS for patients with brain metastasis was longer in patients treated with afatinib following a WRT, because we know that whenever there is a RT, there is a disruption of blood-brain barrier, which may improve the efficacy, penetration of these drugs, and hence the efficacy of drugs. So if you look at the FLORA, we all know that osimertinib is a very good drug. It has a good CNS penetration. So similar data was reflected in the FLORA trial among the patients who had a CNS metastasis compared to standard first generation TKI. There was a clear-cut improvement in PFS from 9.6 to 15.2 months with addition of osimertinib compared to EGFR TKI. The similar, even patients who did not have CNS metastasis, even they also derived benefit. So irrespective whether they had a CNS metastasis or not, they do derive a benefit if you add a osimertinib compared to first generation EGFR TKI. So what about dacomitinib? Do we have any data for dacomitinib? This is a 14 patients data. In that they looked at EGFR mutated non-small cell lung cancer who had a baseline brain metastasis. In them, when these patients were treated with dacomitinib, objective response rate was very high, 92%. That is a very good percentage. I mean, it is almost like 9 out of 10 patients do respond, and disease control rate was seen in 100% of the patients, and intracranial response rates was seen in 85.7%. So this, though the number of patients were very small, they suggested that dacomitinib has a very good CNS activity. Another trial which looked at this dacomitinib versus geftinib, in these patients, those who had those who developed brain metastasis while on therapy, only 6 patients developed brain metastasis compared to 18 patients while on geftinib. Compared to other site of metastasis, we can see that the brain metastasis incidents were almost 1/3 in the dacomitinib arm compared to geftinib, again supporting the activity of these second generation TKI dacomitinib even in the brain. So it was also statistically a significant response was seen compared to other sites for brain. The statistically it was less than 0.05. So it favors that dacomitinib has a very significant activity in brain, and the development of new brain lesions will be less if you use a upfront dacomitinib. So this is a case report that dacomitinib induces an objective response in a metastatic brain lesion of a patient with a EGFR mutated non-small cell lung cancer. There is another case report also suggested that remarkable response to dacomitinib in patients with a leptomeningeal carcinomatosis. We know that leptomeningeal is one of the dreaded thing to manage in a lung cancer patient. If they develop a leptomeningeal metastasis, they have a very poor prognosis. And in this one case, when they managed with the dacomitinib, it had a very good durable response. Similarly, there was another case report which also suggested dramatic response to brain metastasis with dacomitinib. So this is another study which looked at the efficacy of dacomitinib in a brain metastasis patients. In this, 8 patients were evaluated. Out of them, 7 patients had a response to dacomitinib, that is roughly contributes to 87% 87% of the patients. So dacomitinib demonstrated a very good CNS efficacy with in EGFR TKI naive patients in the real world setting as well. So moving on to what does NCCN guidelines? Definitely the preferred option if cost is not an issue. Osimertinib is the preferred category 1 recommendation for a EGFR mutated. However, other category 1 recommendations are afatinib, geftinib, dacomitinib, and nowadays we are also having a EGFR inhibitors with a VEGF inhibitors, either bevacizumab or ramucirumab, or EGFR inhibitors with a chemotherapy. FLORA2 is also addressing a 3rd generation TKI with chemotherapy. But how do we choose? Probably if cost is an issue, or if they have a L858 or mutations, probably dacomitinib is probably the better option in these patients. Moving on to the another important point, safety data. Apart from the efficacy, we also need to consider what are the side effects. There is something called as a class effect with EGFR TKI inhibitors. That is, either they may develop a skin rash or diarrhea. These are the class effects with the EGFR TKI inhibitors. They are very commonly seen with the first generation TKI and second generation TKIs. So in the Lux-Lung trial, which looked at afatinib, the diarrhea incidence of grade 3 or grade 4 diarrhea was 13% compared to 1% in the geftinib, and also again rash, acne were much more in the afatinib, as these were irreversible and they have a pan EGFR activity. So the incidence of these class effects were much more higher in the afatinib. However, liver-related toxicities were slightly higher with the geftinib. In the Archer trial, again, decometinib is not a easy drug. It has a roughly around 66% of the patients required a dose modification due to these side effects. Only 33%, that is 1/3 of the patients, went on to receive a 45 mg. In remaining 38%, it was reduced to 30 mg, and roughly around 1 in 3 patients, that is 27.8%, could only tolerate 15 mg. That is again
so sorry to interrupt, but we are short of running out of time.
Sure. Only one more slide left.
Yeah, sure.
So though there was a, the dose was reduced, still efficacy was not compromised even in those patients who had a reduced dose of 30 mg or 15 mg. We can see that the decometinib did much better than the geftinib. So probably the next question is 45 mg is the right dose, or is it a, like certinib, do we need to modify? Those trials are looking at whether 30 mg is equally efficacious as 45 mg. Probably upcoming trials will address that. Apart from, if you look at the Flora trial, definitely osimertinib, because of a very high specificity, it has a low toxicity, but certain toxicity to mention is QTc prolongation. So one thing should we keep in mind is whenever we prescribe osimertinib, drug interactions, because QTc prolongation may lead to fatal toxicity too. So that is about safety point of view. So the key issue is, how do we choose? We do not know, but certain pointers like L858R mutations, brain metastasis, probably in this either decometinib, or if brain metastasis, osimertinib. If side effects is an issue, probably osimertinib is a clear-cut option. So based on the molecular, and to conclude my talk, EGFR 19 deletion and EGFR 21 mutations, they are not as same entity. They behave differently. Concomitant mutation burden differs with those, and the decometinib has clearly shown that it is as a good efficacy even in those who have a exon 21 EGFR mutations. Need more data on CNS activity because only small set of patients has shown decometinib as a good CNS activity. Probably, with the coming trials, we may know that what is the actual CNS activity of these EGFR mutated lung cancers with decometinib. A repersonalized treatment approach needs to be considered according to the type of EGFR mutation, cost, CNS disease, burden of disease. All things needs to be kept in mind. So we need to evolve with how do we sequence these drugs in EGFR mutated lung cancer. With this, I conclude my talk. Thank you.
Thank you, Dr. Shivshankara. You have very nicely covered the talk. I just want to ask one question. I have come across a patient with exon 20 insertion mutation positive patient. Is amivantamab is available in India, or anybody has got any experience of it?
Sir, it is not available in India, but there are trials going on for that for first line setting, sir. In first line setting, if they have a exon 20 insertion mutations, trials are going on. We can refer patient for those trials. Otherwise, in first line setting, it is not approved as of now for using this amivantamab. It is only if they progress on chemotherapy. In second line setting, it is approved. In first line setting, it is still in trial phase. We can refer patients for trials.
Sir, Dr. Vikas Swamy here. I have two patients. The same situation. First line, we gave the standard chemo. Second line, one of them is on amivantamab and second is on mobocertinib. That is also another TKI which is useful. So I think the drug is going to be available shortly.
Yeah.
Dr. Dubey, can I ask one question to Dr. Swamy?
Yes, sir. Yes, sir. Please. With the
Dr. Swamy, I wanted to know one thing. In real world, where do you use the combination of erlotinib plus Bev or erlotinib plus ramucirumab as shown by you in the NCCN?
Very practical question, sir. Where I have used, even I have used with osimertinib also, bevacizumab and osimertinib. Usually where CNS disease and where there is things are not able to control with this. If we had one patient who was on osimertinib 80 mg, had a brain metastasis, we irradiated, still continued on osimertinib. He continued to progress again in brain only. Then we doubled the dose, 160 mg. Still he continued to progress. At the next revisit, we added bevacizumab. Almost for 1 year, he was well managed with osimertinib plus bevacizumab. Probably at this situation, if I add a bevacizumab to EGFR TK, it is in those with the brain metastasis who are not responding.
Sir, I would also like to add, I have done it for 2 patients with osimertinib. I have not doubled the dose. I have increased the dose to 120 mg. 120 mg plus bevacizumab I have done, and for 7 months, one of my patients has gone up to 7 months, and another is still going on with that this combination.
So you are saying osimertinib plus Bev.
Yes.
So that's like an anecdotal kind of thing. Do we have trials for that?
So there are trials for this first generation TKIs.
No, that I know.
Not
erlotinib
third generation
plus-
TKI, but
Okay.
third generation TKI.
No,
I don't think so. I don't know.
I
the
have two
question was,
patients.
I mean, where do we find a place for this EGFR inhibitors?
Yeah, the question was erlotinib plus Bev, because we often see that in NCCN, but I don't find a place for that combination. So
Yes, sir. In first line setting, I mean, even I have not used even in a single patient first line directly going with either geftinib, bevacizumab or erlotinib, bevacizumab. Those data is there. It has shown a very good PFS and OS improvement with addition of bevacizumab. But
second question was any comments on the combination of pemetrexed plus geftinib, which is the trial? I mean to say chemo plus erlotinib or geftinib versus the data which you showed.
definitely, sir. If osimertinib is not an option, and if a patient is a heng, definitely I would like to put the patient on first generation TKI with chemotherapy. And we were also part of FLORA-2 trial, where osimertinib plus chemotherapy was given. So even in that, the problem with when we add a chemotherapy to the TKIs, tolerability will be an issue. Patients
Right.
will have a prolonged thrombocytopenia. So these issues will be definitely there. So again, it depends upon what patients need and whether patient is young enough to tolerate this kind of combination therapy. So with that,
Right. So cost, I think, as of now.
yes, sir. If osimertinib affordability is an issue and patient is young and fit, with the TMH data, I would like to go for first generation EGFR TKI and chemotherapy.
So 3 patients I am also giving it, sir, in my hospital, and they all are tolerating, because I have also
So
considered
you are
this
giving
young.
pemetrexed plus
Sir,
geftinib.
2 patients paclitaxel geftinib and 1 patient pemetrexed carbo and geftinib.
And then you give maintenance with PEM plus geftinib, and in paclitaxel you give maintenance with pacli plus geftinib.
Only geftinib.
Only geftinib.
Paclitaxel geftinib.
Okay. Cheek. Fine.
Yeah. Thank you, Shivshankara. And we will now move on